So we use SLT as first-line therapy in just about every patient that comes in who is a new patient. So we offer SLT as primary therapy, and I think this is probably the most important role that SLT has played in the management of glaucoma. Patients, of course, have issues with cost, compliance, and side effects of medications. And therefore, the SLT has been a very useful adjunct as used as primary therapy. I think this is probably the most important role of SLT, is its use as primary therapy in the management of glaucoma, and it's really changed the management style that glaucoma specialists use to approach the patient. I tell the patient that that they need lowering of intraocular pressure, and there's two forms of therapy. One is laser, the second is medications. I inform them that the probability of success with the laser is about 90%. That is, that they will achieve a significant pressure lowering without the need of medications, and that there's really minimal side effects. It's an in-office procedure, and there's really no restrictions that they have to be concerned about after the procedure. So it's a relatively benign procedure for the patient. The other option is, of course, to take the medications, pay for them, and of course have to take them every day and deal with the side effects. So many of these patients now agree that they would like to undergo the laser. So we don't have too much pullback on patients sort of refusing the laser. Most of them actually agree to undergo SLT as primary therapy. Now, the studies, there have been a variety of clinical trials, of course, over the years, examining the role of SLT and its efficacy as primary therapy. The first study was actually done by Dr. Shlomo Melamed in the early 2000s, around 2001, 2002. And he demonstrated that when SLT was used as primary therapy, there was approximately a 30% reduction of intraocular pressure in those patients. And that study lasted for about 18 months and showed that pressure was maintained over that time period. Subsequently, Dr. Nagar and co-workers in England performed a number of studies looking at SLT as primary therapy and comparing it to Xalatan as primary therapy. Her study was very nice in that she also looked at the amount of angle that was treated, so 90 degrees, 180 degrees, and 360 degrees. And her study was significant for the fact that when compared to Xalatan, 360 degrees of SLT therapy, SLT treatment, resulted in effectively equivalent IOP reductions to that of Xalatan over the time period of the study. So that was really the major indicator that 360 degrees of SLT treatment was basically as effective as the prostaglandins as primary therapy. The most important probably clinical trial that was then done subsequently was that by Jay Katz and Joel Schumann and co-worker, which is a multi-center clinical trial looking at SLT as primary therapy compared to prostaglandins as primary therapy. Fashioned in somewhat like the GLT study, but that the SLT med study treated patients, not eyes. So either the patient was randomized to SLT or the patient was randomized to medications. That study conclusively showed that after a year follow-up and 360 degrees of treatment of SLT, that both groups showed similar IOP reductions, and there was actually less steps, in other words, the need for additional therapy in the SLT group compared to the medication group. So that being a randomized clinical trial really, I think, demonstrates that SLT is as effective as the prostaglandins as primary therapy. So the development of SLT actually was a somewhat prolonged process and very extensive process, which required really starting from cell culture, developing prototype devices, testing the prototype devices, then developing the specifications that were required to perform the procedure to the extent that it actually would be reproducible in cell culture and then subsequently reproducible in an animal system. That was all done before proceeding to the human clinical trials. So we spent, roughly 5 to 7 years in that development stage with SLT. Once the clinical device was constructed, that also had to be tested as well. And there was significant work into making sure that that laser worked properly, functioned properly, and met the specifications needed. Pulse duration, the spot size, the optics of the laser are all critical in performing this procedure. So in order to obtain FDA approval, of course, that device was specifically tested, and those specifications, the specifications of the device, such that we were able to perform the clinical trials and meet the appropriate goals of the clinical trial, showing that the device actually did what it was intended to do. I think that there is a number of course, replica lasers now that sort of try to take what we call the general aspects of the procedure and probably the general aspects of the specifications and applying to new devices. But those devices really specifically haven't been tested in cell culture, haven't been tested in the animal models to meet the specifications, which we know are much more stringent. So the question is are they, have they reached the level of quote-unquote equivalence to that of the Lumenis device? So in summary, I would like to say that the SLT has really gained wide acceptance both in the United States and worldwide as the laser of choice for treating open-angle glaucoma. It's now effectively replaced argon laser trabeculoplasty as the laser treatment for glaucoma, and I think it's soon to potentially replace medications as primary therapy. So the safety and efficacy of the procedure has been proven time and time again. Overall, it's low risk, and the patients who have undergone the procedure appreciate it, and the effect has been usually fairly long-standing. As we know, there's a lot of companies which have replicated SLT, and of course imitation is the greatest form of flattery. But I think these lasers still do not meet the standards that were in the research that went into the original SLT laser by Lumenis.